Thank you so much for taking the time to speak with me this morning, and it's obviously evening your time where you are. I thought it would be helpful for me to do a quick introduction on how I got to know you and of your work. Since 2014, I've run a charitable foundation called the Giving Tree Foundation, which has focused on early intervention in children and families affected by autism using behavioral therapy. For many years, I believed that this was the type of therapy that would really help my son thrive. He was diagnosed with autism age 2, so very young, after a period of quite extreme regression. It wasn't really until he aged 7 that I discovered there was a lot more going on with him medically that could not be helped by a conventional ABA therapy. We took him to various doctors who then went on to do lots of testing, which included measuring B12 serum, amongst other things such as strep titers, ferritin, thyroid, and so forth. They didn't do much with the test results other than they forwarded us on into the system until we stumbled across an immunologist who decided that he should be treated for PANDAS because his strep titers were very high. We went on to treat our son for just over 18 months and quite an aggressive cycle of antibiotics every 28 days, whereby he would then regress even further after each cycle. We hit rock bottom 3 Christmases ago, and it was at that point I decided to really empower myself and go looking for answers. Later that following year, that's when I miraculously stumbled across a website called b12oils.com and started vigorously reading the site. And I was so fortunate that at the time I had an organic acid test to hand. And through my network in the ASD community, I was told that there was a very friendly and forthcoming biochemist by the name of Dr. Gregory Russell-Jones, who, if I sent the organic acid test, he may have a look at it and be able to point me in the right direction in terms of helping my son. So fast forward now 2.5 years later, having embarked on his R&D protocol, I'm fortunate enough to have you here in front of me today for this interview. There are a lot of people in the wider ASD community and AD community, chronic fatigue community. I want to thank you through me for all the work and kindness and support that you have shown so many people that are ill or have an ill child. So I want to hand over to you now for you to introduce yourself. So welcome, and thank you so much for taking the time to speak with me.
Oh, hi there, Tanja. So thank you very much for your background. I've had a potted history which has led me to this. So I worked on B12 a long time ago. I was involved in cloning intrinsic factor. I used vitamin B12 as a targeting agent for oral drug delivery. And then I serendipitously came across the topical delivery system for B12. At that stage, I knew nothing about autism. I knew nothing about chronic fatigue, knew nothing about the symptoms or what caused it. So I came into it with a completely open and blank mind about it. I did have a lot of time on my hands, so I could look at a lot of things. The first organic acids test I looked at it, I said, oh, okay, what's all this about? And that was with chronic fatigue. Then I got more and more and more of them. And then I realized I didn't have any controls because all of my data was from people who were sick. So I then spent quite a bit of money getting control data. And so then I could start to analyze it to see where the differences were and to try and understand the markers. In chronic fatigue and in autism, people, because they don't know what it is, have done lots of tests. And so they had lots of tests available to send to me for me to look at it and then for me to try and work out what was going on. And so that's where I came to start to group the data from autism and group the data from chronic fatigue. And then basically I could see, well, looks like B12 deficiency. And so then I came up with this, it looks like B12 deficiency, but B12 levels are normally high, which is probably what we found as well, and what most people find. So then I had to find out a mechanism for that, and that's where we came across the fact that in functional B2 deficiency, vitamin B12 doesn't cycle properly, and it gradually becomes inactivated. And so serum B12 levels are very high. Then going through the elementary biochemistry that's been known for 40 years, you could work out why that was going on. And I came up with this concept of paradoxical B12 deficiency, where serum B12 levels were very high, but the markers that we were looking at show B12 deficiency. And this is a common thing with all of the kids that I've had with autism, all the ones that I had. So then I went back in the literature, and you can see that about 40 years ago, autism wasn't very common, but B12 deficiency was a common thing about autism then, but it was absolute B12 deficiency. So it was where the mother clearly didn't eat enough red meat or didn't have enough B12. And then you got the developmental delay, all of the speech problems and everything else that you associate with autism now. So then they said, well, clearly, if in absolute deficiency you can get the condition, then in this paradoxical B12 deficiency, you should get the same. And so then we started, it was first with chronic fatigue and getting people out of chronic fatigue. And then later, people found me like you did through the web somehow. They just found me, contacted me, and then we started from there. So it started with one, and then I've got about 2,000 now, autism. So that's quite a bit of data. They're all the same pretty much, but they're on a spectrum, as you would expect. I'm getting quite a bit faster at reading a note.
Excellent. So I've got quite a lot of questions. I think the most obvious one to start with would be for you to explain your Nexus theory of autism and the 4 main causes of developmental delay.
So one of the things you can do when you sit in an office is go online and look up references. And so I then started looking up developmental delay. And the most common cause of developmental delay used to be iodine deficiency. And cretinism and these things came from the iodine deficiency. So that was one. So that's the single most preventable cause of developmental delay in the world. But when you read the references about it, they don't tell you why. All they do is tell you that iodine deficiency causes it. And the second most preventable cause is iron deficiency. Once again, they don't tell you why. They just tell you it's essential for development, but they don't tell you why. And then one of the things I noticed with the kids is the vitamin D levels were low. And so I looked that up, and then you come across vitamin D deficiency as being a cause of developmental delay. So we already have, now we have the 4. We had the iodine deficiency, the iron deficiency, the B12 deficiency, the paradoxical B12 deficiency, and the vitamin D deficiency. So I then started thinking, well, where is it that these all come together? Is there a nexus? Is there something that they're all involved in which can explain what the problem is? When you look at the incidence of vitamin D deficiency, it's just been going up and up since they invented sunscreen, basically, and it's been going up. So I thought, well, maybe vitamin D is involved in it. So part of the Nexus theory is to go through, and the last step in activation of vitamin D to the active 125-hydroxy D is a step that involves iron. So that's your iron deficiency. Is a step that involves FAD. So that's one of the active B2 derivatives. So there's your B2 or iodine deficiency. To make the protein that does it is an iron sulfur protein. And to make iron sulfur proteins, you need active B12. So that's the nexus of, and obviously you need vitamin D. So there's your 4th one. So that was the activation of vitamin D. So there was some interesting data that came out a couple of years ago about the need for sunlight on the eye to activate vitamin D in the brain. So it's slightly different to the rest of the body. You need this stimulation on the eye. So that was part of it. So then what does vitamin D do? And so then you come across another thing where vitamin D works with melatonin in the brain to stimulate neuronal stem cells to divide into to differentiate into oligodendrocytes. And they are responsible for myelination. And you can show this delayed myelination in autism, And so then you have this Nexus Theory, the nice bit, you've got to activate vitamin D, and you need B12 for the production of melatonin, and there you have this myelination, delayed myelination. It's associated with poor speech development, with coordination issues, which are big with the kids, and a lot of developmental things. That's the one big side of the nexus, those two coming together.
So what are the main symptoms when you're looking at B12 deficiency?
Let me go to my cheat sheet. So the major ones were developmental intellectual delay, hypertonia, tremor, seizure, and failure to thrive. In addition, they generally have speech and linguistic problems and social impairments. So we know the social impairments, they have this thing where they turn away and they don't want to participate, and they seem to be disjoint and they don't bond well. They have behavioural disorders, which is one of the common things that people say that you can't control the kids. And they also have this problem with the fine motor skill and gross motor movement that you see with them. So they can't stack blocks when they should be able to do. They can't turn things over. So these are things that a developmental person would be able to see much easier than I can. And I must confess that I've never sat in a room with a child with autism at any age between 2 and 10 or 15. So this is definitely not me who's looking at this. This is somebody else who's doing this analysis.
So new age autism, that is the next thing I want to discuss. You've obviously covered on it that it's paradoxical B12 deficiency, where the serum B12 is high but is largely inactive. So why is that?
So the issue is that part of B12 cycling is that it normally involves introduction of folate somewhere in the cycle. And a folate backbone starts, is methylated to 5,10-methylene tetrahydrofolate. And then that has to move through an enzyme called methylene tetrahydrofolate reductase. That enzyme requires FAD, or the active component of vitamin B2. So there's where the iodine comes in, because you need iodine, selenium, molybdenum to activate B2. Without that, you don't get the folate coming through. So you can't properly cycle B12, because normally methyl B12 donates its methyl group to homocysteine to make methionine. And if you can't regenerate that methyl B12 with the folate, you have inactive B12. That inactive B12 starts as cobalt-1 B12, and then it goes to cobalt-2 B12. And normally to regenerate cobalt-2 B12, you need two vitamin B2 components. One is FMN, flavin mononucleotide, and the other one is FAD, flavin adenine dinucleotide. So in functional B2 deficiency, you start to rapidly generate inactive B12. So you now have functional B12 deficiency. So this is different from classical B12 deficiency due to lack of diet. So in this instance, you can have plenty of B12, but it's basically inactive. So it's not doing what it's supposed to do, and that's to methylate, or be involved in the methylation cycle correctly.
Thank you for clarifying that. So tell me a little bit about the resolution. What can parents do to start helping their child?
The classic thing that happens to me is I get an email from someone and say, my child has autism, what can I do? It won't be, hello, how are you going? Or I've heard about you or anything else. It'll be something quite blunt. And then I ask them to send me data so that I can see why. I'm assuming they're B12 deficient, but you need to establish it. So The first thing I'll ask for is a note, which you had, organic acids test, and that tells me whether they're B12 deficient, and it tells me whether they're B2 deficient. It also tells me whether they're iron deficient, and it has an indication of vitamin D deficiency in it as well. There are quite a few markers that I use. The other thing is, because I know of the connection with iodine, selenium, molybdenum for B2, I normally ask for a hair metals test analysis. Because there's an odd belief that autism is caused by mercury, they always get their hair tested. And one of the things they totally disregard is the essential metals normally. And when you do that, you find that all the kids are deficient in one of iodine, selenium, and or molybdenum. So that comes up in the test, so I can see that. So then I've got to a way of saying to the parents, well, you need to fix this deficiency first in iodine, selenium, and or molybdenum so that you can have functional B2. Because if you try to address the B12 deficiency without that, it doesn't work. The other test that's useful is the TSH, T4 and T3. So they're measures of thyroid activity. So I can see whether they're looking hypothyroidic or not. And it doesn't take much deficiency of selenium and iodine to be hypothyroidic, functionally hypothyroidic. So this is often missed because the ranges are set too high. But there's a few papers that are coming around to where I am, and that is that it basically, if your TSH is above 1.5, you're starting to be hypothyroidic. And the more you are above it, the more you are. I have some of the kids who've got TSH levels of 8 or 12. So they're pretty massive. But basically, if you don't get it down to under 1.5, they still show deficiency in B2. And if their genetics is not optimal, that has a more profound effect.
Okay. I mean, we've been using TSH as a starboard for my middle son's ongoing supplementation with the oils. And it's interesting because I can always see when the TSH has gone above 1.5, some of the symptoms that were previously there before we started the protocol reappear. And that's my cue then to gently tweak either iodine, selenium, and in some cases, molybdenum.
When you replete, so let's say you've got a swimming pool full of iodine, selenium, and molybdenum. When you replete, you can take quite a bit out, and it doesn't seem to affect function. But when you're trying to fill the pool up from being very low, it doesn't need much to take out before you really affect the function. That's one of the things I've found. So you need about 150 micrograms a day, and I think there's 25 milligrams of iodine in a replete person. So you can see there's quite a bit to get up to. And some of the kids are incredibly low in iodine. I really don't understand how they can have a diet that's so low, and they will just get a tiny drop of the iodine, and that really affects them strongly. So they've obviously been very deficient.
Yes. What are some of the things that would affect iodine when parents are trying to get their children replete? You know, childhood illnesses that tends to take a hit on the iodine pool. Are there other things that parents should be conscious of?
It's more the B2 pool in that case. So when you're trying to deal with an infection, you activate a lot of enzymes that need a lot of B2, so you can become deficient. The same thing happens when you have COVID or a lung infection like that. You get this respiratory infection. Respiratory infections seem to be very bad for this. They seem to consume large amounts of B2. And there's quite a lot of kids who've been doing really well, and then they get COVID and they really regress strongly. So that affects it. Using antibiotics affects it because you have to inactivate the antibiotics. So in the process of doing that, you use cytochromes generally that use B2 and iron as part of the inactivating antibiotics. Antifungals are terrible. Some of the kids, they'll get an eye test and they're misread and they say, oh, the child's got fungus, that's why I've got a yeast infection. We've got to treat them with antifungals. They generally go backwards because of that. The other things that can affect it, we've discovered, is that if there's high levels of bromide or fluoride in the water, it can alter the thyroid function or the thyroid's ability to deal with iodine. The others are goitrogens. So many of these things, they don't make a lot of difference if you're replete, because you can deal with them. But if you're not replete, you can't deal with them, so they can have a bigger effect. For instance, cassava or tapioca, which is often in kids' puddings, is derived from cassava, and it has a cyanide group in it. And cyanide can then activate B12. You normally have an enzyme to kick it off. That enzyme is dependent upon vitamin B2. So if you're B2 deficient, then these things can have a much greater effect than if you're not.
Okay, kind of moving on from how parents can help their children. As you know, the autism community and therapies surrounding it, it is a multi-billion-pound industry. And there are a lot of different theories that permeate this industry. And I have some questions around this if you'd be happy to answer that. I think one of the big ones is the gut-brain axis?
It's definite that the brain can affect the gut. So you can send signals from the brain down to the gut. So there is an axis that way. The neurotransmitters, or the putative neurotransmitters that are involved in that, are similar in the brain as in the gut. So you can see these metabolic markers change. In vitamin B12 deficiency, one of the things that happen is that you don't make sufficient melatonin. So when you don't make melatonin, this affects your gut. And so your gut permeability changes, the villi on the gut runt, so they look as though they've been sloughed off. You don't get differentiation of the gut. And when you look at the markers, you say, oh, look, they've got a lot of serotonin here. And I think that's possibly where this idea has come from. But the enzyme that makes serotonin in the brain, although the mechanism that it makes it, by which it makes it is the same, is a different enzyme. And the problem is when you do an OAT, organic acids test, you're getting more of a reflection of what's going on in the circulation in the body, so to speak, than what's in the brain, because there's a bit of a barrier there. So it's there, but it's not what the issue is. The issue is the B12 deficiency. It destroys the integrity and the maturation of the small intestine. You get incredible overproduction of serotonin, you get streaming of fluids in the gut, and that's where the idea is that these kids have got these massive infections in the gut, and that's what's causing all the problems. The problems really come from the B12 deficiency. And it's interesting because in the hair metals test analysis, you actually see a major shift or a major drop in the heavy metals, essential metals in B12 deficiency. And when you start to fix it, they all seem to right themselves. So it's actually quite a diagnostic to see that in B12 deficiency, the markers are all over to the left. And as you start to cure it, the markers come over to the right. The other things that happen are that you need melatonin for maturation of the villi in the gut. And one of the enzymes there is diamino oxidase, DAO, as most people would know. And that's responsible for inactivating histamine. You also get reduced production of lactase, which means that the kids are susceptible to lactose and hence the milk intolerance. So I think that probably covers it.
So just sharing from my own experience, my son previously was casein dairy intolerant, and now he can quite easily eat, drink dairy. And that's been one of the major improvements that we've seen. Also, you touched on melatonin and sleep. Again, this was a child who would sometimes not sleep in a 24-hour period because he was simply so hyper. And now I can't wake him up in the mornings. So again, it's a positive change. And this correlates obviously with the ongoing testing, notably the TSH, and just staying on top of the cofactors, the B2, the B12, and the multivitamin. I have a few more areas that I'd be grateful if you would cover, and that's on genetics. I know that's a big one.
I find the genetics argument quite amazing, really. When I first came in, because I didn't know, I got lots of 23andMe sets of data, and I developed a program to screen. I looked for nearly all the SNPs that I could find that might be useful, and I developed a program to analyze the 23andMe data, and then I ran all these comparisons. And I was lucky enough to get some of the mothers and fathers' data as well. And so I ran them. And generally, the mothers were worse than the child. So that was the first thing I noticed as far as any methylation SNPs or anything. It looked like the child had survived in a bad womb, so to speak. The thing is that it was a naive concept. And why I say that is that the incidence of autism about 25 years ago was 1 in 1,000. The incidence of autism now is nearly 1 in 30 in the US. Now, in order for that to be genetic, every child with autism would have only bred with every other child with autism. No other child in the world would have been born to anyone but an autistic mother. So you cannot genetically explain what's going on. And the next thing is, we know what's going on because we know it can all be accounted for by the Nexus Theory and by B12 deficiency. So these came out when people had no idea. what amazes me is, given the data that I had, that they had no idea, because it didn't take me long to work out what was going on. And so there's massive amounts of money that's been spent on the genetics of this. And then they're saying, oh, we've got 500 genes or 200 genes or 100 genes that are responsible for autism. And I'm going, okay, really? So how are you going to fix that?
Yes, very useful. And thank you for sharing when we're discussing the gut, because obviously diet plays a huge role in all of this as well. I know that you advocate or propose to parents to try to follow Mediterranean style diet. Now, can you go into that as to why that would be a good idea?
The Mediterranean diet has been touted now for many things. If you want longevity, they say eat the Mediterranean diet. If you want to prevent Alzheimer's, eat the Mediterranean diet. And when you ask the nutritionalists what is very good about the Mediterranean diet, they wave their arms around and they say, oh, it's got protein, carbohydrates, and fats in it. I'm thinking, well, yeah, well, diet's got that in it. Why, it's Mediterranean. But one of the things that it does do is it has a good cover. And because it's on the Mediterranean, a big part of the diet is seafood. And not only is it seafood, it's seafood that's been derived from the Mediterranean Sea. And for those of you who are in touch with your geography, the Nile brings all the nutrients from Africa into the Mediterranean Sea. So you're getting a lot of selenium and molybdenum and iodine in there. So seafood, of course, is a big source of iodine and selenium. So you can see that if you have a diet that consists of a lot of this, these two deficiencies go out. The seafood they tend to eat is high in iron, and high in iron foods are generally high in vitamin B12. So you've got, you're covering 2 or 3 of these things already. And being in the Mediterranean, of course, and I know that you like to go near the Mediterranean quite often, is you get lots of sunlight. So you cover the vitamin D. So what's good for autism is good for dementia, is good for general health, because you're covering these minor nutrients that people don't talk about. And so of these, iodine and selenium are huge.
And on the topic of sunlight, I know that you are very pro getting, obviously, as you said, getting children, adults into the sun. And you were not a big advocate of sunglasses. And I just wanted you to cover that topic as well.
When I was growing up, it's probably before you were born, one of the things we never used sunscreens. The incidence of autism was 1 in 1,000, and we didn't know anyone who had it. We were out in the sun, and then there a few people got melanoma from overburning and everything, and this big slip-slop-slap campaign came in and everybody covered up. We had no rickets before that. Now they're measuring the success of the campaign by rickets appearing back, something that we abolished 100 years ago. Sunscreen is advocated in some part, like in England, and even I saw in Canada and in northern parts of the US, where they're all vitamin D deficient or their levels are very low. So I'm thinking vitamin D is such a powerful thing for you. Low vitamin D is involved in obesity, diabetes, Alzheimer's disease, autism. So when you look at all those, you think, well, is it good to block the sun out completely? So that's the skin part of it. Now, you mentioned the eyes and covering the eyes or not. So this is the new bit of data that's on the website under vitamin D, is that it seems you need light stimulation of the back of the eye to send a signal to the brain to turn on the gene that's involved in making the 125 dihydroxy vitamin B12. And so this is where vitamin D is separate in the brain to in the circulation. There's a separate enzyme that's working in the brain to the circulation. That enzyme is turned on by exposure to sunlight. Of course, that when we moved away from the equator, one of the things, we went from very dark eyes to blue eyes, and we're trying to let more light in. And we know it's involved in myelination of the brain. So if you're worried about glaucoma and some of these other things, you only need glass. You could have clear glass, because those wavelengths that do that are blocked out with glass. But you need the wavelengths that are involved in stimulating the back of the eye.
Another area that very briefly touched on was obviously this notion of heavy metal toxicity. There was a big wave, particularly in North America, parents doing chelation on their children. So I'd be grateful if we could cover that off too, and what your thoughts are on that.
All right. So part of the process that I go through is asking parents what processes do they put their children through. And a lot of them say, oh, we did Cutler and it didn't do anything for us. And I looked into this, and a lot of chelating agents are very non-specific. So if you have something that will chelate lead or copper, it will often chelate magnesium and calcium. And these are essential in the circulation. The chelation that was used for heavy metal toxicity is generally used after you get a big dose of it. So for some reason, you might imbibe or ingest a large amount of heavy metal, and then they put it in and they try to rip it out while it's still in the circulation by chelating it and binding it up and then having it excreted. The first thing is that I've yet to see a hair metal test analysis that was consistent across the board. I mean, there's some kids who've got virtually no mercury in them. If it was a generic thing, they'd all have it. So they don't all have it. The next thing was the chelating molecules that are there. So the two big molecules are DMSA and DMPS. They've both got thiols on them. So they're reducing agents in a way. You have a very powerful reducing agent called glutathione within your cells at 5 millimolar. So these things are nowhere near that concentration. They're about 100th that concentration that you have. And I know some people have said they went backwards. Then there's another one called ALA that they add in, and they're claiming that ALA chelates as well. But ALA doesn't chelate because ALA, the two sulfides that are in there are disulfide bonded. So it doesn't do anything. Can I prove that? Yes, I bought all the reagents in and I tested them. So ALA doesn't do anything. It doesn't, the others will change the color of copper, so they reduced it. So you've got to be very careful too with this concept, because the concept assumes that you can inject or imbibe DMSA or DMPS and that it will magically cross the gut wall. Yes, it probably does. And then it will magically hone to some place in the brain that hasn't been identified yet. And once it's there, it will somehow selectively pick out your heavy metal, this unidentified heavy metal, just by the way, because we haven't proved it's there. And then it's got an exit strategy to take it out of the cell and then dump it. Now, I've worked on drug delivery for 25 years. I know of no such mechanism. And this is when you've got a concentration of 5 millimolar glutathione inside the cell, which is far in excess of anything you're putting into. So the concept is highly flawed, I would say, as a polite way of explaining it. No, it doesn't work.
Okay, thank you for explaining the biochemistry behind it as well. I suppose one of the newer areas is autoimmune induced autism, which I suppose ties in what we've already discussed. And there's this notion of PANDAS, obviously caused by strep, or PANS, which is other things such as Lyme. What can you say about that?
Okay, so all of us get exposed to strep as kids. And I got my regular bout of strep every year until Dad took my tonsils out, basically. I used to work in Rebecca Lansfield's lab, and she was the person who typed the group A strep. And when I was there, they were up to 96 serotypes at that stage and still finding more. And the common thing about them was that they have this group A polysaccharide, and until you're an adult or until you're about 18, you can't mount an effective immune response against the group A polysaccharide. And so you keep being infected. So we all get that. So if you go and measure antibody titers to group A strep, you'll have them. You'll have them to IgM, to the polysaccharide, and then you have a series of antibody responses to the M protein that's on the surface of it. Now, every time you'll get lots, every time you get an infection, you'll get a new one. So you'll pair with lots of antibodies, which you should. I mean, that's what you're trying to do. So you're trying to eliminate these bacteria. Now, when I was at the Rockefeller, they were all also working on rheumatic heart disease and a couple of other conditions that are supposed to be due to post-streptococcal. So there's post-streptococcal glomerulonephritis as well. And so definitely there are things that are post-streptococcal rheumatic heart disease. So they're definitely there. They're there. But the thing is that if you're deficient in iron and B2 and vitamin B12 and vitamin D, you're more susceptible to all infections. So which is first? Which is it chicken or the egg? It doesn't cause it, I mean, people who get post-streptococcal rheumatic heart disease, they're not sitting there and having brain fog and all these other things at all. And those with the nephritis don't have that either. So it's not causing, those diseases are not causing anything. You can certainly isolate the bacteria. I mean, you can go into nearly anyone's throat and you'll find group A strep. You can go into, a lot of women have group B strep in their vagina, and and meningococcal disease comes from group B streptococcus. So you can definitely get meningococcal, group B meningitis. So yeah, you can have streptococcal infection, but we know what causes autism. These are all things that have come because nobody could see the wood for the trees. And they said, well, if it's not that, it must be something else. Let's develop a theory and run a few papers and then test. And you can do this. You can find antibody titers if you look. We all should have antibody titers to group A strep, all of us.
One thing, at least in our case, was our middle son never used to get ill. He would never have the common cold or norovirus or any of these things that were, filtrating around the schools. And now, 3 years in to the protocol, we're seeing that he gets a cough, he gets a cold and all these things. So can you tell me a little bit about the immune activation, looking at it from B2 and B12?
Let's be very careful here that we're jumping to something that we have no evidence for.
Okay.
What you do have evidence for is that you change the proteins on the gut wall as you mature your B12. You also change the polysaccharides that are on those proteins. Now, the way that these organisms attach is via specific bindings to proteins or specific bindings to polysaccharides that are on the gut wall of the mucosal system. So you don't know that the reason that he's now getting more infections is because you've actually expressed more things for the bacteria to bind to. So you don't know that. So there are lots of, you could sit down and start going through this whole gamut of possibilities now, none of which you can prove, but would all be reasonable theories. But, you've got an observation that's an observation.
Yeah, thank you. Another area that I'd be keen to cover is, again, the increasing popular treatment, stem cell therapy, particularly in America, Panama, Mexico. Do you feel that it holds any true scientific merit?
Let's go back to what we think is happening in the brain of these kids. The kids, as they're developing, have got bucket loads of stem cells. They've got plenty of stem cells. The problem is you haven't turned them on. So you didn't get them to differentiate into oligodendrocytes. So the stem cells are there. And the thing with stem cells, if you want them to differentiate, you need to give them the right trigger, or they won't differentiate to what you wanted. They just sit there and be stem cells. And you can have very long-lived stem cells that just sit there and they're waiting for the right stimulus to come along to differentiate and become something else. So we know the kids have got lots of stem cells in the brain, and certainly in tissue culture of brain stem cells. The thing is, we know that with low vitamin D and low melatonin levels, you don't turn on your own stem cells. And so they don't differentiate into oligodendrocytes. And that's where we came way back in the theory on what's going on. So why would you go put the child through all this pain and everything of injecting stem cells into its brain when it's got plenty of them there? And even when you do inject them, you still got to turn them on.
Okay, thank you. Another question is around SFN or sulforaphane. That seems to be another popular treatment, if we can call it that. Would you mind covering that?
Okay, so this was an interesting thing. One of the things about vitamin B12 was it's the little group on the top. The cobalt combined lots of little moieties on that. And one of the things that combine is cyanide. And in fact, cyanocobalamin is B12 with a cyanide group in it. And the things that you get the cyanide from are isothiocyanates. So sulforaphane is a compound within the isothiocyanate group. And so it seems to me that you have something here that can inactivate B12, and then you want to use it as a treatment. So isothiocyanates inactivate vitamin B12. And unless you have functional B2, you can't kick the cyanide out. So it doesn't sound like a good idea to me. The other problem that you have with these things is that if you have a child who's hyperactive and you turn off the activity, you might think you've done good, but you might have just dumbed them down so they're not responsive. And so they've gone into a mute state, so to speak. So you have to have a person who is a good behavioralist to analyze and say, is the child better, or is he just gone into a quiescent state and he's sitting in the corner quite happily, or in some state that we don't know? Remember, people with dementia, they don't make a lot of noise and run around as well, and their brains are not working that well.
Yeah. Is there anything else that we want to cover that we haven't covered?
You were on the paleo diet before. My wife's a nutritionist, so we have discussions about diets. And the thing is that people say, oh, get on the paleo diet, get on the paleo diet. And they make these assumptions on the people there, whether they're healthy or not. Got to remember that in those days, the people were very active. So they're healthier anyway because they're moving around. And the life expectancy wasn't great. It's about 32. So the paleo diet wasn't doing them a lot of good as far as life expectancy goes. So did you want to put your child on that and he's going to die at 32, or do you want to...
Yeah. On the topic of diet was around wheat germ, glucotinine.
One of the things I did 20 years ago was I worked on lectins and agglutinins. And I worked on specifically to do what these papers suggest, and that is that your gut wall is covered with all these sugar moieties. They're called glycolipids and glycoproteins, glyco being the sugar bit. And these wheat germ agglutinin, peanut agglutinin, a lot of these things that give you allergies if you haven't mounted a good response, can bind very well to the gut wall. When they bind to the gut wall, they can then internalize, and you can actually couple things to them. And I've been able to drag nanoparticles in with them. So, and I could see them go through the gut wall, and sure, they will take them in. The thing is that what your body is supposed to do to all the dietary things you have is mount antibody response to them. It mounts antibodies responses to them to neutralize them so they don't do you damage. And so, yeah, if you feed rats or mice wheat germ agglutinin, they mount a fantastic antibody response to them. If you put them in tissue culture, which is one of the things that they're used for, they make cells divide because they can cross-link receptors on the surface of the cells, and that can be a stimulus to make them divide. So they certainly can do that. But the thing is that we've all been eating peanuts and everything for years and years, and wheat germ for years and years and years. And most of us are fine as far as I know. So what we've got, there are probably more foods in a vegan diet that has them, which tends to be heavier on nuts, such as the peanut agglutinin, wheat germ agglutinin. Peas even have an agglutinin. Lentils have them. Soybeans have them. You're taking a lot out of your diet if you don't want to eat them. But we know what causes autism. It's not eating beans.
Do you want to say anything about the transdermal delivery versus oral delivery?
Okay, so this is an interesting thing. So when I was doing my work on B12, it was in the days when you could buy radioactive B12, which was made a very, very useful tool. And so you could do studies on uptake of molecules through the skin or orally, or look at the distribution when you inject them, or when you inject them IM, intramuscularly, subcutaneously, IP, and you could look at the distribution. And you could see, then you could determine how much of the dose would get to anywhere. So the thing is, when you have oral, the amount of the dose that gets in is at best 1% of the dose. Very low doses, you can get 60 to 80% of the dose in, but it's very limited. So in a human, that might be 1 to 4 micrograms that you can get in by the specific intrinsic factor mediated uptake. If you then keep loading that up, you get about 1% that gets in, and that's through a non-specific phagocytic mechanism or an antigen sampling mechanism in the gut. So if I was to give a milligram of B12 to a human, I might expect to maybe get 10 micrograms in. So then that's the stuff that got across the gut wall. Then where does it go? We could never find any evidence that we got any of that dose into the brain. So you didn't get much in, and what you got there didn't go to the brain anyway. So it wasn't particularly useful. The different, if you inject it subcutaneously, you could get a much higher distribution, of course, and now you're getting 100% in, or as much as you can effectively inject, or your efficiency of injection. The same with subcutaneous, and the same with intraperitoneal. because of where you inject them, they have a different time course of distributing through the body. And then you can start to get meaningful amounts to go into the brain. And we found with the transdermal delivery system that we had that the amount that you get in is very high too. And we were using some very big molecules. We used B12 is 1356 molecular weight. We were using proteins that were 150,000 molecular weight, and we could get those through the skin. So we know that that goes through. We know we get a very high dose through. And what you want is a long, protracted delivery system, which actually transdermal is pretty good that way. And so you want the transport into the brain to be maximized. So every time there's a little shuttle vector that goes into the brain, you want it to take B12. You don't want to have a shuttle vector going in without a B12 on it. So you want something that's there, persists for ages, and maximizes uptake. There have been so many studies, that at least there was one study with 20,000 humans in it where they were trying to alter metabolic activity in the brain through oral. Use very high dose oral, and they got nothing. So it's 20,000 humans that they tested on. I have people who had the chronic fatigue have been taking oral and sublingual and lozenges, B12, and basically sucking them until the dentine came off their teeth, and they're still not helping their chronic fatigue or the symptoms they had in their brain. But in contrast, when they are on injections or when they're on our transdermal, it has helped in the brain. So we know that's working. The problem with the oral is that when you have very low dose oral, you're supposed to protect the B12 from degradation in the stomach with a protein called haptocorin, and that binds to it and protects it from the acid environment in the stomach. The trouble is when you keep dosing up higher and higher and higher, there's not enough haptocorin to coat it all. So you then have a lot of material that can be acid inactivated. So what you tend to find is that people who are using high dose B12 orally, their serum levels go up very high. And I think it's in Canada now, where they're refusing to give injections anymore because they've done studies where they show that with oral, the serum levels go up higher. The people aren't getting better, but their serum levels are high, but the B12 is inactive. So taking oral, if you're replete, if your functional B2 is okay, obviously you're taking oral when you eat meat. But if you want to take it when your B12 deficiency is high, it interferes with normal uptake into the cell. So if I inject all of B12 that's active and it's gone into the cell, then it's all active. But there'll be a certain amount of B12 any cell can take up. Now, if I mix the active B12 with inactive B12, such that say maybe the inactive B12 is 10 times the active B12, when the cell takes it up, only 1/10 or only 1 in 11, more correctly, of the material that goes in is active. So most of the stuff is inactive. So when you keep giving people inactive B12, basically, they have more problems. And you then have to wait until you get rid of this inactive material before the stuff works. So there is a delay in cleaning out this inactive material. So I definitely think you can get what you need from meat, but to actually use a supplement to get it to the brain. And that's the other thing is that when you're born, you stop your brain in utero. So you stop your brain while you're a fetus, and then it goes in the fetal brain, and you have a certain amount there that seems to have to last for most of your life. What you're topping up is very, very little. So once that's inactive, it's very hard to fix as well. So that's another problem you have. That's where this slow trickle of active material, and so we only have active material in our transdermal, is of such great benefit, I believe.
Well, I believe that too, because I'm reaping the benefits of that transdermal delivery system here. In terms of transdermal, there are certain things that can affect the skin, and i.e. then the delivery of various oils. Do you want to name a few?
So the oils themselves are dependent upon the skin being warm to go in, and that's because the skin lipids freeze at about 16 degrees, so it's very hard to get anything in. Also, the composition of the fats in your skin depends a bit on your diet. And so we have had some instances of people who are on strange diets where they seem to need more material than others. Now, we haven't done a time course in them, as far as it goes in, as far as time to go in, but it seems that there's something that's going on there. We have changed the formulation slightly now, and we're just waiting to scale it up. And in those people, it seems to go in better. So it was changing the worlds. So then it's the actives. The question I think is you're trying to ask, and that is that
Yes.
iodine can obviously be converted, or iodide can be converted to iodine by an acid environment. And so then the thing that your thyroid takes up is iodide. It's not iodine. Sulfite and molybdate both are bound to calcium and magnesium. And also, if you have vitamin C, it changes them so they become reduced. And you can see this in a test tube when you add it and you have a clear solution, and over time it precipitates. So this material precipitates and it's useless. So a lot of, I don't know how many people, because I don't do the survey of women cosmetics and what they put on their children, etc. But a lot of cosmetics have got antioxidants in them. So antioxidants are reducing agents, so they will reduce sulfite, or reduce molybdate, so they're inactive. A lot of them have vitamin C in it. It's supposed to be good for the skin. There's this fabled belief that you can get vitamin C through the skin in water, so, and that will affect it. So we generally don't recommend using anything but plain soap, and don't use these fancy cosmetics with all the antioxidants and everything in them.
And on the soap front, and obviously the water that people are showering in, bathing, it varies globally, I think. In London, we have huge fluoride content in our water, which will obviously be detrimental to the uptake of the oils.
It won't affect the uptake of the oils, but if you have a lot of fluoride, it can complete with iodide for transport into the thyroid. So that's an issue. The biggest issue is probably the hardness of the water. I mean, we're lucky enough to live in Sydney, and the water's quite soft. And if you boil a kettle, you don't get a ring of white. I lived in Madison, and if you boil water in the same pan for more than a week, you always got a white scum in it. So you obviously have very hard water with lots of calcium in it. So in that instance, that calcium can affect sulfite or molybdate because it binds to it and makes it insoluble. So there is a slight issue with that. The other issue we've had with things like improving the hair metal analysis is some people have quite a bit of arsenic in their groundwater. So this has been an issue as well. You see their hair metal is quite high in arsenic. Another issue is with people that are on the gluten-free diet is if you go to rice is quite high in arsenic and lead, which is quite curious if you believe that heavy metal toxicity causes autism, and why you would possibly put a child on a diet that was full of things that could possibly cause autism if they had autism.
Okay, on this kind of side of things, one thing from our own experience and speaking to a lot of other parents is the effect that chlorinated water can also have on iodine specifically.
Yeah, so that's curious, isn't it? Because so many people have filtered water now, and filtered water, the issue won't be there. And it's a question of dose, really. So if you're drinking a couple of litres of tap water a day, it's probably going to have a problem if it's got enough chlorine or fluoride in. If you're only having enough to clean your teeth, it won't. If you are boiling your water and making tea out of it, it might be an English thing that you might do. We do it here as well. Then the chlorine and the fluoride will go off when you're boiling it. So that's not so much of an issue. But you have sodium chloride floating around in your body, obviously. So it's not that much of an issue with the thyroid. So, yeah, these are caveats, and they're in the literature. I think possibly the take-home message is really that modern-day autism is very similar to classical B12 deficiency, mediated neurodevelopmental delay, except that modern-day autism is not due to absolute B12 deficiency, it's due to functional B12 deficiency. And the functional B12 deficiency comes from functional B2 deficiency. And we've discussed why that is. It's a deficiency of iodine, selenium, molybdenum. In the UK, the soils are very low in selenium now. And so often I find from hair metals analysis that the selenium deficiency is almost uniform when I get them. New Zealand's known to have deficient soils. A lot of Australia's now got deficient soils, especially in the wheat belt, because we exported our selenium over to you people in England, so you could eat it. It was in wheat, but you didn't know. And a lot of Australia now has molybdenum deficiency up the East Coast. In the US, the rate of obesity is inversely proportional to the amount of molybdenum in the soil. So you can track that state by state. I see this is going to be a big problem. Unless we do something about it now, unless governments recognise it now, it's going to be a big problem because we're all going to be suffering from the same deficiencies. Selenium and molybdenum. In the UK, selenium deficiency is becoming a huge problem. And so hopefully it's discussions like we are having now that will help people realise how important these things are in your diet and how important it is for us to know it. I mean, Europe is low in selenium too. When I get hair metals analysis from Europe, routinely they're selenium deficient. The vitamin D is a huge issue as well. The problem is, how do you change it? How do you get people who are using high SPF makeups, the mothers, to not use it? How do you get the cancer societies to say, listen, if you're going to take this, you need to take vitamin. If you're going to use our SPF 60, you need to take vitamin D because you're going to be D deficient. You don't hear that. It gets worse. I mean, it's depressing. It can get depressingly worse. In the UK, the two major supermarkets have taken iodine salt off the shelves. I mean, we worked out iodine 100-something years ago.
In terms of selenium, obviously what you're using in the oils is quite different to what you're reading online because you're using selenite.
That's correct.
We didn't discuss it earlier, but I think it's an important point just because a lot of people won't be using that.
All right. So one of the ways you can find out whether your soils are deficient is to go and see what the farmers are using. And when I discussed this molybdenum deficiency with a doctor, he said, oh, that's curious because my goats, they've got this condition and it's been identified as molybdenum deficiency. If you talk to the guys who are making the fertilizer and you ask them what they're using selenite. So in cattle and everything, they've worked it out. These guys, they know they have to put the right thing in. It's too expensive not to. Selenite works and works very well if you're B12 deficient. Selenomethionine, which is the one that a lot of people use, is treated like methionine in the body. So it goes to proteins that have methionine, and so you get this selenomethionated proteins. You can process it through to get the selenium off it if you're B12 sufficient. So if you're functionally sufficient in selenium, so that you're now functionally sufficient in B2, so you're functionally sufficient in B12, you can process selenomethionine. But if you're not, you can't. So selenomethionine has also been used because it's toxic. So at very high doses, it has anti-cancer effect. At very high doses, much higher than what we recommend anyone takes. But this is cited as a reason for not using it. So, it's important. It has to be selenite. And with molybdenum, there's a molybdate transport system. So you have to use molybdate as well.
Okay. Very important points, actually. Glad we just got that in there too.
There's one more very, very important thing, which I've discovered. And that is that they're putting these things now into multivitamins. So the vitamin industry has realized that there's a call for these things. You have a Pregnacare, I think it is, a multivitamin for pregnancy, and we have an Elevate, which is made by Bayer. Now, both of them have calcium and copper. They have selenite in them, but they have calcium and copper in them. And so we found out by personal experience that the Elevate, the selenium doesn't work in it. And when I went back and I had a look at the preparation, and it's got calcium and copper in it. So this selenite is not being taken up, even though it's in the product. And that's because this complexation with divalent cations like copper and magnesium and calcium and zinc. So you've got to be very careful of these preps that they don't mix too much in them so that they don't work. So, and it's annoying because the thing you want to recommend to a pregnant lady is the right sort of multivitamin. And here are the two premier multivitamins, one in Australia and one in the UK, and the formulation's wrong.
so much, Greg. I really just can't thank you enough for doing that. And hopefully somehow we'll get the message out.
Yes. That's what my hope in all of this is, that more people are aware of it, that we can turn around this dramatic increase and drop it back to its 1 in 1,000 from 1 in 30, because to the medical system it's just huge. The cost of the NDIS and these other things where these kids are going, and the parents believe that the child is never going to be cured. They get disability funding and the child is on for life. It's terrible. It's destructive to the family and the child, and it can be prevented.
Yeah, and you're so right, as you've said on numerous occasions by email, that it's all about prevention and educating people, especially expectant mothers, or even before you fall pregnant. And I just wish that I had known about you before I got pregnant. But, luckily I'm in a situation now where Con is much improved, and it is really down to you, and I can't thank you enough. And it's just something that I want other parents to be able to experience, because, the heartache of having a child with disability, it's very taxing. Thank you so much.
Well, good night then. I'll stop the recording.
Yeah, thank you.
All right. Thank you very much and good night. Bye. Bye.